And I'm sharing my screen, and hopefully everyone can see it. And Aaron, you'll be manning
Yeah, I'll be
the,
letting people in
the
within
wait
the
list.
waiting
Yeah.
room. Mhm.
Yeah. So welcome. Yeah, there's some pop-ups of people wanting to be admitted that I still see. So um, okay. All right, well, welcome everyone. I'm going to try to review in about 20-25 minutes the inspiration and the, let's just say, evidence that I accumulated over the years, over a decade ago, about what was needed and what we developed and how Kylon was born. So most of you know what Velcro is, and as you'll see, I'm going to go to the next slide so you get an idea why I went back to this. I invented this bristle brush for gynecology to take biopsies in the 90s that became a commercial product in the 2000s. And you can see it looks like a brush that's twisted. And in fact, it was a patented brush that's twisted, and it has little spikes coming off of it that could actually take samples. At the time, brushes were thought to be cytology tools, and they still are today. But my idea was to get something a little more penetrating, so you can get deeper into the tissue and get deeper cells from the tissue. In fact, that's what's done in the oral cavity today with this particular brush. But it's not a true biopsy device as it was developed, but it evolved into that. But it had some pitfalls. It was a little difficult to remove the tissue from the brush, whereas I thought, well, Velcro is a lot different. And you can see it's hooked over. It's really meant to catch the loops and fasten tissue. So it needed quite a bit of re-engineering. So I was able to re-engineer Velcro um, with many facets that were engineered. Most of them are trade secrets. But when this turns out to be pressed into tissue, it can actually frictionally abrade it quite well. And it actually shears off pieces of epithelium into the stroma that lies below, but not to the level where it causes a lot of debris, a lot of bleeding. Not only can it be used for biopsy, it can be used to debride necrosis and crust and um, epibulum and slough off of wounds as debridement. But as you can see the picture below, that twisting motion actually lifts the epithelium off. I use the blades of grass versus the sod analogy, where if you did that, the sod would come off the lawn and bring some of the soil with it in pieces that are intact diagnostic pieces of lawn. So if you had a disease on your front lawn and you wanted to use Kylon, you press and twist it, and clumps of sod would come and it would also trap them. So it's a multi-patented technology where you can rake it for its cleaning, or you could press and twist it for curettage. And it can remove the tissue automatically into the rows of hooks. We've turned this into quite a bit of a commercial entity. First on the left side with colposcopy, where you press, twist, or place in a canal and rotate, flattening the hooks, excavating the tissue, trapping it within the hook array. You're targeting lesions, so you're getting a very enriched sample. But one of the things about it is you can cover a lot of surface area with this, where you can't with a little punch biopsy, nor can you with a punch biopsy of a wound. And the depth of anything that's cutting with those surgical tools on the right can cause excess bleeding, whereas with the Kylon fabric, it's modulated by the amount of pressure, the amount of direction, how you sweep it versus twist it. And obviously, there's one thing that a brush can't do that fabric can do, and that's you can put it on things. So you can see people in the wound care entities thought, well, maybe it's better that we have a bigger device, maybe nurses or allied health professionals, or even specialists might want to have something faster, bigger, and they can modulate the pressure with their finger. And so we invented soft K-Cot a couple of years ago, and it's really caught on. It's very efficient and fast, as you'll see. So for the cervix, for those of you who are attending because you're cervical colposcopists, um, you can see the cervical biopsy involves pressing it, splaying the hooks, letting them penetrate, twisting it with key turning motions back and forth, 6 of them, excavate the tissue. It enters the hook array, it's trapped, and it's diagnostic, and it's taken off. And you'll see in a second how it's brought to the lab. For the endocervix, these are just snapshots from a video we have, and it actually works using friction. So you can see the frictional heat on the right panel on the upper actually causing the excavation, the loosening of the epithelium from the stroma with minimal amount of bleeding. And then when it comes out on the lower left, it's completely trapped within the hooks, and it can be snapped off from the shaft of the device and sent to the lab. This is a little depiction of what it looks like with wounds.
Closer look at how Kylon works to remove tissue. The pressurized raking or rotational motion of the device entraps biopsy specimens, making it efficient and gentle on the body. The tip is designed to break off in the vial for biopsy, providing an efficient and provider-friendly solution for tissue collection. See the soft K-Cot in action on a human wound.
That's the gentle sweeping motion, not the twisting.
Kylon is also instrumental in
That's the
diagnostic
twisting to
sampling
get the
of a wound
biopsy.
culture. Closer look at how
Now, I'm going to show you the banana video, we call it, because this is what we show in our trade shows. I think it really does showcase the different levels of what you can achieve with debridement.
I'm going to introduce you to the Kylon medical fabric and the instruments used for wound debridement today. This is Kylon fabric on what we call the soft biopsy plus D, which means that it not only can take a biopsy, it can also debride wounds. It's good for 3 by 3 centimeter wounds and can do selective or non-selective debridement. I'm going to show you the wound hygiene level, the mechanical debridement level, and the selective surgical debridement level using this product. When the hooks are upright, it's a brush that traps tissue, and when it's flattened, they turn into curettes. And you'll feel that when you put it on your own hand to use some of the non-sterile for demo. So a very light stroking will allow for some wound hygiene. But some moderate raking, you can see that there's now a deeper debridement going on. That's mechanical into dermis. But if you find a semi-solid spot or you have to get into the subcutaneous space, you press and twist it and rotate it, and you can see I've made a crater here. If I need to debride a larger area, more like up to 6 by 6, the same Kylon fabric can be deployed on a finger cut, which I'm going to show you now. And this finger cut can be steadied with your thumb. It's got the same Kylon hook array and the same debridement levels of mechanical or selective by pressing and twisting, flattening the hooks, turning them into curettes, while also entrapped tissue. Sometimes when you're debriding and you're doing a lot of solid tissue, you might get a lot of entrapped tissue. You may feel that it's holding back some of the hooks from working, which is rare. But if so, the package that it comes in can be peeled back to about that level and filled with some sterile fluid or some hypochlorous acid. And once there's some liquid in there, I'm going to show you that we can immerse the tip and clean it really effectively without having particulates flying out and disturbing the environment. And by cleaning it out, you can see that I've cleaned it and I'm able to continue to do it. And I only advise you to use it once for that. You won't need to use it more than once if you're using these for small wounds. These are for 6 by 6. Once you've debrided the wound base and you have exposure of biofilm, The soft biopsy is really a single use, and that's for taking a biopsy. It's not as fortified as the soft biopsy plus D. It's great for a brief excavation and a biopsy of the wound base where you trap tissue, and then you can separate it at the score mark and send it for culture, molecular testing, or even histology. These are tangential biopsy specimens. They're not punch biopsies. They're curettings that are trapped within a hook array. Last but not least, because these are mounted perpendicular to the wound, they're good for flat wounds, but what about if it's in a crevice? What if the wound's between the toes or in a fold in the skin, or even a shallow tunnel? You always want to see the hook while you're debriding. You don't want to go blind into tunnels, but let's say it's the toe space. You can actually press the hooks down and rotate this and rub it, and you'll be able to debride the wound. Especially at the nail bed, sometimes you can actually shave away debris at the nail bed or use the rounded tip to kind of clean out the tip as well. So all of these have the capability of sending to the lab for a sample. Usually you don't want to send in necrotic debris. You want to have a pre-debrided wound, and you want to be able to take the sample separately. Even the soft biopsy plus D can be used for this as well. It's got a score mark as well.
So these are the devices that we sell currently. We have two more in development. One is going to be released soon. I can just generally say it's a handle device that's got the size almost of this K-Cot. A lot of people like handles. The K-Cot has a lot of advantages. Patients don't fear it, but with handle devices, you get maybe some advantage because it's stiffer at the platform. You can get probably a sharper cut. But you've got soft biopsy, which can be used for cervical or wound biopsies. You've got soft biopsy plus D that has the added advantage of being able to be tempered or fortified to be able to withstand a longer minute or two debridement, which, the nice thing about Kylon is it doesn't take very long to debride a wound or to take a biopsy for that matter from the cervix, the vagina, or the wound bed for right now. You've got the two sizes of endocervical curettage, the soft TCC, and the exact same product used in instructions for use for wounds is soft K-Ret for the folds or the small tunnels. You got soft K-Cot, which is this really nice finger controlled. There's something about feeling the wound bed with your finger, and unless you try it, you don't know what I mean. The it's not a plastic cap on your finger that retards the ability to feel the wound. This is a flexible fabric. You can actually feel the wound as you're debriding it, and you can feel the patient sensitivity along with shaving. You can do very light paint brushing with any of these, and you get just hygiene. You can do some deeper strokes, which is like mechanical debridement, or you can do the press and twist, which is sharp, selective surgical debridement equivalent. They're single-use disposable. That means that you're not going to cross-contaminate. In fact, in the GYN world, they're being used all over the world in a lot of public health measures where a lot of different trained clinicians are using them to take cervical biopsies. Very safe, especially where there's cross-contamination risk like with HIV. And people always, of course, people ask, what's this cost? Um, it's not it's not a pedestrian utilitarian product, but it's not highly specialized with a lot of cost. They're about the average price that people pay is between the $5 range. Our list price is going to be, as of March 1st, $5.75. But there's a lot of different ways to bring the price down with volume price discounts or contracting. We have a very high reorder rate for these products. So people, when they convert to Kylon, they don't abandon it. Do they use it exclusively? Some do. Some put it in the mix of the armamentarium of the tools they want to use to take samples or debride wounds. And speed is everything, and they're very fast. And for a practice that's looking at cost, what does it cost for your time? What does it cost to retrieve tissue while the patient's either in the stirrups, while you're messing with the tissue in a forceps, or trying to control bleeding from a debridement in a wound? And how about the patient acceptance? That you may say, okay, a metal curette cost me maybe 60% of that cost, 70%. Well, you're getting a lot of extra value for the 30% more. That's the finger cut. And there's really a good, it's just patient friendly is what we try to teach. Most people don't fear a finger, they fear a sharp instrument. Uh, Tracy Kimball's on the line here, and she did these debridements. So I'm going to show you what she did when she was a pioneer in the beginning. So that's a mixed ulcer, DFU venous ulcer. You don't hear the audio, but this patient was talking, and I believe she was partially sensate, and only antiseptic was placed on that. And that's the mechanical debridement level. You don't see any pressing or twisting. And you can see how this, let's just say coded 97597 type debridement is going very fast. As I said, time is money and very precise. You're not getting a lot of bleeding. You're getting that micropunctate bleeding. And she's showing you the debris. She's also showing you what you shouldn't do, which is try to use a gauze because they're hooks. They aren't Velcro, but they're hooks and they will catch and they'll delay you. They may just rarely dislodge a hook. We don't want to do that. So we dunk the finger in what I showed you in the other one in the pouch. This is a venous ulcer. These can be very sensitive. And with the venous ulcer, she's using her thumb and she is just paintbrushing. That is not like highly frictional. And she's causing immediate micropunctate bleeding, which is beautiful because she's revitalizing that wound, pulling out the epibulum, getting the granulation tissue off, and creating a little bit mild inflammatory immune response, which, by the way, in the cervical world has been proven in evidence-based research. So people always say, okay, I'm using this thing. Now, is there any special thing about what I use it and when I code for? No, because in gynecology, there's equivalent to a cervical biopsy and equivalency to a endocervical curating specimen. So all of the relevant codes on the left are coded when we use Kylon devices to remove tissue for diagnostics. The same with the wounds. We've got the 11102 and 3 for the wound tangential biopsy because it's transepithelial. Wounds are disrupted skin. It's going deep enough to be considered a biopsy, and thus it's coded as such. The same with institutional non-selective debridement and 97602. You've got the 97597, 8, and 9 for the CPT code for mechanical, and you've got the 11042, 45, 46, and 47, although I wouldn't advise you using it for bone. It's just not strong enough to debride bone unless the tissue is so soft on the bone and you know you're going to be able to take it. The other thing is people say, well, I'm using a lot of camps, a lot of grafts or biologics, and I want to heal a wound. I want to stimulate it. Well, we've got some research going on that as far as putting skin grafts and trying to vitalize the wound before you put the graft on. And micropunctate bleeding happens to be very good for it. And perforating the blood vasculature with the array of hooks is actually healthy for wounds. And you see a little bit of blood pooling at the base when you're ready to place the graft. And in fact, some companies actually sell products that intentionally put blood clots on wounds. So we believe this is something that we're going to look at in the future as an added advantage of the Kylon methodology. This isn't a Kylon methodology now we're talking about. And the A code for the Kylon device is a miscellaneous code. So it's a sterile instrument used for wound care. And when you're going to code it for your procedure note, you could use that code. We don't have a specific code for Kylon devices at this time. It's a sterile surgical tool used in wound care. So I've reached the end of my talk already. Boy, did I do it pretty fast. There is 10 minutes left, which is what we planned, which is amazing. So Aaron, I'm going to have you open it up so that we can get some questions answered.
Alrighty, anyone can unmute themselves now if they have any questions they'd like to ask.
Hi, I'm sorry. I was a few minutes late. I was seeing a patient in the clinic, but For use for cervical biopsy, can you review the technique for using that?
Yes, absolutely. Let me get one.
Thank you.
So the cervical biopsy tool is used perpendicular to the lesion, and you want to fasten. You want to take the speculum and make sure the cervix doesn't wiggle. So you're kind of holding the cervix with your speculum, and you're aiming for the lesion. When you get to the lesion, the nice thing about it is, unlike a punch biopsy where you really can slip off the lesion and maybe miss it because there's mucus, or you can plant it and then you twist it 6 times back and forth like key turning. And if it's a bigger lesion, you could actually shave more of the lesion off. So if targeting error is not as much of a factor with Kylon, when you get the specimen, you look at it, because no lab's going to make tissue in the cassette if you didn't get it. So you have to make sure you've got tissue in there. People ask, well, what about how many lesions can I take? As long as there's space in the hook array, you can go for a second site. So you can go, and then you'd have to say 6 and 3 o'clock is the origin of this specimen. If you're at a teaching institution and you want to do cytocolpohistopathologic correlation, you need to know what the colposcopic image is correlated with the lesion. Then you got to use separate brushes. And you just say, that's what 6 o'clock, it looked like high grade. I'm guessing it's high grade. And then you teach with that. So that's my answer. And let me just skip to the endocervix. The endocervix is amazing because patients don't feel something that has a smooth and a rough side. So when it goes in, it's tapered like a dilator. And when it goes in the cervix, all you do is make sure there's friction against the wall and twirl it 3 times one way and 3 times the next. And you can hear the friction, and you'll hear it. And then once you get the specimen, you snap the specimen. Then you don't have to mess with the curette, and nor do you have to mess with biopsy forceps. So this is automatic. You take the specimen with soft biopsy, you snap it, you drop it in the vial. The lab takes the tissue off. You get the speculum out of the patient much faster. Next question. Thank you for the question. Anybody else? Okay. So I'm going to make my own question.
I'm sorry. I was having trouble getting off mute. So with the endocervical curettage, right now, particularly in my practice, I'm seeing a lot of older women
Yes.
who require colposcopy. And of course, the
Yes.
key to older colposcopy, particularly when you get around the perimenopausal, postmenopausal age,
Right.
the endocervical curettage. And
Yes.
being able to get that tissue. And if you don't, you have to invite them back. If they actually come back, then unfortunately, because of their immune system, many of these women don't clear the HPV virus, within a year or 2 or 3. So they're coming back annually, for the colposcopy, which, as you can imagine, no one looks forward to. Eventually, you lose them. And so I was hoping that this might be something that, not to convince people to come back in that sense, because a colposcopy is not a fun procedure for anybody. It's at the very minimal.
Right.
But at least it won't be provide such a bad memory in terms of the colposcopy they had, but when they unfortunately may have to come back next year. So that's what I was hoping as you're talking about the cervical curettage, but also on the replacement for the punch biopsy.
Right.
You can do up to 2 biopsies, 2 biopsy sites, and sometimes there might be more. So you would say you might need, say, a couple of these devices. Say if you had 4 biopsies taken the cervix, is that what you're saying?
Yeah, I think we had this big trial in the National Institutes of Health all over the world, and they wanted to conserve, they didn't have a lot of pathologists to prep specimens. They asked, how many sites can you take with one? And I think the rule of thumb is if there's space in the tip of the device, you can take more than just one site. But once it fills, it's full. All you're going to do is squish the tissue out from the last biopsy onto the cervix. So you don't want to do that. So there's a one-to-one average, but sometimes people can get two sites. Um,
Okay.
um,
It doesn't affect management because you don't really care what spot in the cervix the
right,
biopsy came from.
right,
If you're going to
right,
do a leap, you're
right.
going to the whole area. So,
Who is this speaking, by the way?
Stephen Sutherland.
Oh, thank you, Stephen. So, I think the endocervical curettage is a gift to the women. I coined compassionate colposcopist for a reason, and I I coined the phrase compassionate colposcopy because this curettage with an endocervical curette, the endocervical curette really hurts, and this is evidence-based. Shows that the pain score out of 10 of patients who had a randomized clinical trial was 6 for the curette and it was 2 for this. And my thought is that simultaneous smooth and rough rotation, patients don't know whether they're feeling something smooth or rough. It's akin to what a dentist would do, and they pull on your cheek with pressure while they're putting the needle in your gum to do your anesthesis. So this is sort of the beauty. The endocervical curettage is extremely unique in the fact that you're getting a 360-degree sample of the endocervical canal because it's in the canal and then it's going around the entire canal. With curetting, it's linear, so you have gaps. But thank you for that comment about the endocervix. Any other questions? We've got about 3 minutes left. Let me talk a little bit about the wound care. Um,
We have a
this,
question on the comments, Dr.
do you have
Lonky.
another question? Okay, can you read the comment?
Yeah, any references available to review research on these devices?
Yes, both sites, histologics.com and histologicswc.com, have a references or a resources tab. And in both of them, there's a list of all. There's also in the OBGYN, there's a research publication, a research summary. There's about 8 publications on the endocervix, and there's about 6 presentations or abstracts and or like writings on the wound care. They're all on the website. The things to highlight about OBGYN is the biopsies are at least equivalent to punch and curette biopsies. That was the first one. The biopsies are much more abundant than curetting on the second one, the Diedrich paper, with a higher yield of high-grade disease. The pain threshold is also evident in those patients. And then we have some evidence on immune stimulation using wide local excision LEAP as a reference. So after they get treated, they get LEAP, and you look under the craters, and lo and behold, there's inflammation going on, which indicates there's some immune reaction going on. Wounds, there's a beautiful, like a review manuscript being prepared right now for one of the wound journals that highlights all the smaller studies that have already been presented or published. Any other question? Any other chat? Do you want to finish up, Zuhal, with the...
Yeah, so thank you all for joining. I hope you guys learned something today. For all the attendees, we have 20% off up to 500 devices. And if you guys have any questions, please email us, call us. All of our information is on the websites for both women's health and wound care. It was great having you guys here and hopefully see you next time.
Thank you all. Appreciate it.